I had been struggling with depression for many years, but it just seemed there was a point that the floodgates just kind of opened and I just bottomed out. I got so depressed, I was sucked into this dark black tunnel and there's nothing for me to grab onto to stop it. I've had far too many experiences with attempted suicide. I overdosed almost monthly. There's no way to really describe the deep, deep pain when you're real depressed.
Although we have safe and effective treatments for depression, many, if not most, patients in this country don't receive those treatments. And this issue was pointed out back in 2001 with the publication of a very important document known as the Chasm Report. And it pointed out that the healthcare system in this country is broken. Perfect care, high-quality care, is not making its way to the patient at the bedside or in the clinic. We began our work, and one of the earliest steps was to define what we mean by perfect depression care. What would it look like? How would we know if we're doing perfect care? We wrestled with this issue for many months, and then one day, in a small group in which I was participating, we were trying to answer this question, and a nurse spoke up and said, "I believe if we were doing perfect depression care, nobody would kill themselves." And at that moment, that issue became crystallized for us.
Perfect depression care is getting the patient the treatment that they need at the right place, at the right time. Our focus is that patients shouldn't just feel better, but they should feel an absence of the condition that they've been afflicted with. That would be that they have no depression whatsoever, that they're fully functional in their lives.
If you see a cancer patient, an oncologist sees a cancer patient and the patient dies, the oncologist doesn't say, what did I do wrong? But if you're seeing a patient with depression and the patient commits suicide, all these thoughts about what would you have done wrong, come to your mind. Now, I know for sure that because I followed the guideline, I did everything I can. It's an affirmation that you're here to save lives and you really tried your best.
As a result of this work, we've produced a dramatic improvement, not just in depression care, but an unheard of reduction in suicide risk among our HMO population.
I am among the living because of the overwhelming, complete, comprehensive care and support that I have received at Henry Ford from the beginning all the way to today. There's nothing that compares with the type of help I've gotten here.
The stigma also in the community has been that it's something bad. It is bad, but it's an illness. It's the same as measles or cancer or a common cold. It's something that can be treated in the right atmosphere.
People should care about good mental health treatment because suicide is one of our top killers worldwide. Suicide is actually the number 11 worldwide cause of death. I did a review of research dollars spent on conditions that kill people. HIV and AIDS in this study was about the number 15 killer, but the treatment of HIV and AIDS received 5 times the amount of research dollars that the treatment of all mental health issues receives.
I can't emphasize how sick I was, because people look at me today and would never picture me as a client who's in and out of the emergency room, to a point in my life now where I'm thriving. I've reclaimed my life.
Of course, it's one thing to hit your target, it's another to keep hitting it over and over again. And that's really the challenge of this work. We don't want to lose our momentum. We want to keep moving forward. We want to spread this work beyond just our department into all of general medicine.